Good afternoon, everyone. It is 12 on the dot, so we will get started with our work session for today. Welcome, first and foremost. My name is DeAnna Hansen, and I'm a program officer with New Jersey Healthcare Quality Institute. New Jersey Healthcare Quality Institute's mission is to improve the safety, quality, and affordability of healthcare for everyone. Before we dive into today's agenda, I would like to thank you all for your dedication to improving health equity in New Jersey and for our out-of-state attendees across the nation. During today's work session, we will give you a brief overview of the Maternity Action Plan. Then we will transition to hearing from our subject matter experts on data collection and usage. We'll play a short activity before we enter our breakout rooms, and then we'll come back together at the end to have a group discussion and close out for the afternoon. Before we jump into the content, I just want to go over a few housekeeping items to ensure we have a smooth and efficient session. So this meeting is being recorded and it will be posted on our website as a resource. So if you could please make sure that your microphone is muted when you're not speaking, this will help minimize any background noise. It'll also just help us have a more productive and focused environment. As we go throughout today's agenda and session, if you do need to step away, please feel free to do so. We don't have any built-in breaks. So please, like I said, step away whenever you need. And as I mentioned, there is a recording in case you do miss any content. We also do not have a designated Q&A portion, but rest assured you can still ask questions. We do ask that you use the chat feature to leave any comments or questions. You can also directly message them to Vanessa, who is named as VG Quality Institute. You can also hold your questions to the end of our conversation for our group discussion at the end. If for any reason you have any technology issues throughout today's session, please send a message to Jacqueline, who is one of our co-hosts for today. So the Quality Institute, in partnership with many organizations and individuals across New Jersey, created and released the Maternity Action Plan, which is well known as the MAP, in July 2022. The MAP is a holistic approach to making New Jersey the safest place in the nation to give birth and raise a child. The MAP provides a directional path forward in 4 critical areas: building the maternal workforce needed to achieve birth equity and quality, collecting and using data to improve equity and quality, reforming payment systems to drive holistic maternal infant health care, and improving community-based social supports. So in 2023, we began putting the MAP into action, hence the title MAP to Action. And similar to today's session, we hosted virtual work sessions focused on each section of the MAP. We had doctors, lawyers, leaders of community-based organizations, and government officials all speak to our audience about how their work is improving maternal child health. To view recordings and resources from our 2023 series, please visit our website. You can also use your phone to scan the QR code on this slide, and we'll also make sure to send out the link to all attendees afterwards. Additionally, we hosted an in-person convening that allowed us to bring together our virtual attendees to connect in person and promote collaboration and connection building. From our virtual series and our in-person convening, we molded these 6 maternal infant health values that you see on your right, and these are based on the main themes our attendees repeatedly brought up. We use them as a core to our discussions at our in-person convening and continue to use these values as a central tenet of the MAP work. We hope that these values are in alignment with your focus work as well. Today, our topic is collecting and using REaL, which is race, ethnicity, and language data to improve health equity. Our goal for today is to improve your understanding of why collecting REaL data is important and how it can be used to improve birth equity outcomes in particular, and why having this data is essential to improving patient and hospital safety. We know many of you are interested in learning about data collection and usage, and more specifically, the type of data that is being collected and used. We're happy to have you all here for today's timely discussion. Now, if you've ever done a Google search for race and ethnicity data in New Jersey, you probably ended up on the Department of Health's State Health Assessment data page. The data displayed on this site is from the U.S. Census Bureau, which collects data once every 10 years on race and ethnicity. Now, if you look at the SHAD data, especially for maternal infant health, you will find that the outcomes for many of these measures vary by race and ethnicity. Seeing these gaps and then finding ways to address them, whether that's by narrowing or completely eliminating them, is the main reason why we are focusing on REaL data. But in order to do this, we must have good data. So this is why we are also focusing on the collection and verification of the data. Another important part of collecting and using REaL data is the categories or definitions for different groups. At the federal level last month, Office of Management and Budget and the White House announced revisions to standards for collecting and presenting federal data on race and ethnicity. Across the federal government, agencies will be required to update and use one combined question for race and ethnicity, and encourage respondents to select as many options that apply to how they identify. We will be discussing these changes today. Other entities like National Committee for Quality Assurance, or NCQA, are also focused on REaL data and quality measurement and reporting. As of this year, a total of 22 healthcare effectiveness data and information set, better known as HEDIS, measures can be stratified by race and ethnicity. HEDIS measures are widely used performance measures in healthcare that assess the quality of care provided to patients. Having data stratified in this way can help identify what type of interventions are needed and where they should be targeted to improve outcomes for underserved populations. Our speakers from Outcomes Architects will share background and best practices in collecting, verifying, and using REaL data, as well as their views on the education that is needed in this area. Afterwards, our speaker from Leapfrog will discuss how hospitals are being asked about their collection and use of this data, and how it relates specifically to equity and maternal health. Finally, at our September 20th event, you will have further time to join an in-person workshop on REaL data collection. And as we share this topic, it's important for everyone, not just healthcare providers or insurance providers. It's really important for everyone to understand why REaL data is being collected and how it will be used. By understanding the importance of providing accurate race, ethnicity, and language data, the public would be more likely to provide this information when asked for it. Similarly, staff who are responsible for collecting this information should be trained to appropriately ask these questions and explain its importance should they be met with hesitance from a patient or client. During today's session, we will focus and discuss REaL data in the framework of maternal infant health. And we ask that you think critically about how REaL data impacts this subpopulation's health equity and outcomes. We also know that this problem spans wider than maternal-child health, and we will spend time looking at the impacts of REaL data on the broader healthcare system. So without further ado, I would like to move us into our next portion of today's work session, which we will be featuring the outcomes architect. And I would like to introduce our wonderful expert co-facilitators. So first we have DeAnna Minus-Vincent, who has tackled the toughest issues plaguing our country today: equity, poverty, housing, health, and education, to name a few. Drawing from a broad range of lived and learned experiences, DeAnna currently acts as the managing director of the Outcomes Architect. In this role, DeAnna serves as a key advisor for several nonprofit, philanthropic, health tech, and trade organizations as they seek to create equitable solutions that advance whole person care. Immediately prior to this role, DeAnna served as Executive Vice President and the inaugural Chief Social Justice and Accountability Officer for RWJ Health. I would also like to introduce DeAnna's counterpart, Tracy Parris-Benjamin, who is a master's level licensed social worker, integrator, and equity champion, who works to sustain support for advancing diversity, equity, and accessibility. Ms. Parris-Benjamin currently acts as the managing partner of the Outcomes Architect. In this role, Ms. Parris-Benjamin serves as a key advisor for nonprofit, philanthropic, and health systems as they seek to create equitable solutions that advance whole person care. Immediately prior to this role, Ms. Parris-Benjamin served as the Senior Director of Health Equity and Community Health at Horizon Blue Cross Blue Shield of New Jersey. Ms. Parris-Benjamin served as the Senior Director, and really her work translated executive strategy into tactical implementation, designing and operationalizing health equity frameworks and blueprints to raise awareness and impart the need for cultural organizational shifts. Ladies, so happy to have you join us for today. We will share your slides shortly and looking forward to your presentation.
Thank you so much, Brianna, for the warm introduction and for the great overview of REaL data. We really appreciate it.
Yes, thank you, Brianna.
So really, this is just an overview of REaL data. We're really going to jump into the meat of it in September because we could talk about this all day long. Next slide. So every person is unique. We all know that. And we all have a story and a background to share and tell. Next. And in getting healthcare, we have so much that our doctors and our clinicians and our care providers need to know about us. But oftentimes, and as I looked at those who are sharing our screen, we don't wear our sticky notes on our clothes or on our foreheads so that people know who and what we are. I know I didn't put mine on today, and I see Tracy didn't either. So how are people supposed to know in those 15 minutes who we are? Next slide. So today we're really going to talk about what data elements are critical to deliver quality healthcare, what is REaL data, why it's important to collect REaL data elements, what are the barriers to collection, how REaL data should be collected, by whom, and when. Next. So this slide will just provide a backdrop, and it really talks about what data elements are critical to deliver quality healthcare. And we could spend an entire conference on this, an entire semester on this. And if you were to ask me during my time in healthcare what that would be, it would have changed over time. Even 5 years ago, I would have talked about demographic data. I would have talked about SDOH screening. But in the past 3 or 5 years, I've gone through some health challenges. My family has gone through health challenges, and it would still have changed. So really looking at basic demographics, so name, age, marital status, real data, SOGI data, so sexual orientation, gender identity, social factors, so, but more than just an SDOH screen. So your living situation, your access to supports, safety concerns, ability to afford our prescriptions, lifestyle and behavior, so dietary choices, but not just can you afford food, because as someone who used to be 120 pounds heavier and someone who had a heart attack in the past few years, it's not that I couldn't afford food. It's, as I told Tracy, it's that I liked it fried, dipped, glazed, dunked, all of that. So really, what are your dietary choices? Similarly, my father-in-law just went through a big incident, and he likes to cook his food in the morning and let it sit on the stove. So really, what does food preparation look like? So really spending those moments with your healthcare provider in a different way. Substance use, stress. What are your levels of stress? Is it because stressors of poverty, or is it because you have a really crazy, busy job? Is your stress normal levels of stress or astronomical levels of stress? Medical history.
DeAnna's frozen.
Oh, am I frozen? Am I still frozen?
Maybe it was me. Go ahead.
You're good on my end. Thank you.
Okay. Thank you, Tracy. And not just your medical history of, what is my blood pressure today, but what is the trending of my blood pressure? Because a lot of times we all have a baseline. So for instance, my blood pressure is really low. My baseline is 86/68. So when my blood pressure was 120/70, and they said that's really great, it's not really great. So what is that trend over time? Because 120/70 for me was really high and should have triggered something. So really being able to look in the EHR at trending at every visit, and then listening to your patient. Family history, comparison based on demographics, which that gets into the real data. So what does that comparison look like compared to other people who look like you and are culturally like you? And then your medical concerns. Tracy, is there anything that you want to add to this slide?
Just really quickly, I think, the real data is what we really want to focus on. But when you think about medical concerns, they are often the things that people don't want to talk about. It's the stuff that people are embarrassed to share. So it might be that you are experiencing incontinence, or maybe that you're constipated. And these are critical things that can mean a bigger picture. And the importance here is to start to get care teams comfortable with asking questions in a way that they are traditionally probably not used to doing it, and not solely for the physician or the nurse practitioner or the clinician, I should say, but for the medical team to start thinking about how do they incorporate the feedback that they're getting when they're taking the weight, when they're taking the blood pressure, and sharing that with the physician. So that becomes a comprehensive visit. So that would be the only thing that I would add there, DeAnna. When we think about medical concerns, they tend to be the things that people brush off, and stuff that people have learned to live with. Sometimes it's, I've dealt with swelling this long in my life, so I don't feel I need to bring it up in a visit, because I just deal with it. And that's a really important thing for us to kind of distinguish.
Thank you, Tracy. And the reason we wanted to talk about all of these data elements is I think they need to be spoken about in a comprehensive way. You can't pull real data out without also socializing it with your care teams and your patients, that this is how you provide a standard of care. And we know once we talk about barriers that this is critical, especially as you socialize it with your patient populations. Next slide. So what is real data? And I know DeAnna gave us a really great overview of this, but we want to next talk about how to collect, why it's important, and what are the barriers. Next. So real data is about race, ethnicity, and language data. And why is it important? It's important for all populations. It's important for both your internal populations and your patient populations. It helps your care team communicate effectively, thereby reducing incidents of miscommunication and therefore issues of quality in your facilities, because we know that more issues of quality happen to people of color and people where English is not their primary language. And that is documented time and time again in literature. So by making sure we know about people's language and their culture, we can reduce those things and help and better close that gap. It aids in the efficient discovery of potential health concerns by looking at how cultures may have similarities. It helps to measure and address health disparities if, in fact, we're collecting it correctly, because then we, as a overall medical community, we can see how these things pair together, and there may be some disparities in different ways. It informs workforce needs if we're looking to create culturally concordant care. And it improves community relations if, in fact, again, this goes to workforce, if, in fact, we want to hire people of different races, ethnicities, and cultures to go out and provide community relations, if, in fact, we want our communications to reflect the communities that we serve. So really just helps the entire continuum. Next slide. Is collecting data enough? So we know that there's been talk over several years that race is a social construct. So there is the debate whether collecting race data matters or whether we should just focus on the individual. And but there are some definitive disparities by cultural nuance. So I wanted to just pull this quote out, and the entire quote isn't necessarily critical, but I wanted to show the other side of it. So by identifying the race or ethnicity of a person or group, participants may provide information about the generalizability. So we know that we can look at the cultural nuances of a group as a whole. For instance, we know that women as a group have high incidence of heart attacks. We know Black women present differently in that group. So when someone presents, it allows us to make some generalizability, but it should not be considered absolute or viewed in isolation. So it's kind of 6 in one hand, half dozen in the other. You need to look at the generalization, but then you also need to look at the individual. So I think the debate has validity on both sides, but you need to look at the person, but you also can make some quick assumptions and narrow things down by collecting this data. And the better job we do at collecting the data in smaller increments, as you'll see, we will have more success in this space and be able to tease out more better outcomes. Next slide. So what have been the barriers? Because it's not a New Jersey problem. It's not a particular system problem. It's a problem across the board and across sectors, not even just in healthcare, on how we collect data. We lack standards. We've lacked standards. I'm sure as you have gone about filling out different forms for healthcare, for school, there's been different categories. My favorite is always more than one race, which to me just doesn't really tell you anything. It could be anything. So that's the biggest thing. We've lacked standards across the board. Categories are limited and data fields are incompatible across sectors and organizations. There's confusion about race versus ethnicity. And I believe it was in the late 90s when Hispanic was broken out as an ethnicity, and we didn't really socialize it with our Hispanic, our patients and consumers in the Hispanic population, to say that, well, the federal government really only considers Dominicans as Black and all of the rest are white. So if you don't tell people that's what your expectation is, and that's not how people see themselves, then there's, my friends, they're like, I'm Puerto Rican, or I'm Mexican, or I'm Guatemalan. And then when it came to fill out race, they wrote other. So it was confusion about race versus ethnicity. And therefore you had a lot of other or refused to answer under race. And it was just confusing for everyone. Limited staff to collect the data, and then limited staff training on an ongoing basis. And also negative perceptions regarding the use of the data, which then created embarrassment. People were embarrassed to collect the data. I know when I worked at RWJ Barnabas, our registrars, they didn't want to ask the data. They didn't want to ask the question. People didn't want to answer the questions. I've heard people say, well, is this just to treat me worse? So they didn't want to answer. People didn't want to ask. I've been in other healthcare facilities for my own care where they would have the list and they would just turn it towards you, which one best applies to you, because they didn't want to say the words out loud. So it's just a lot of negative perceptions around it. And again, that gets back to the overall wheel and the overall questions as a piece of the conversation. And also talking about how you should ask, and we'll get to that as well. And I think we've found across the board, and there were some studies done in New York with New York City hospitals, that really the best way is self-assessment and being able to self-reflect and answer those questions, because it's really best and people want to answer along with SDOH questions. But again, that gets to socializing it with our patients, letting them know that this is to provide you the very best standard of care. And then you may see that statistic that most hospitals do collect this data, but it's not collected cleanly because we don't have the right categories. We're not asking it, and we have all these other barriers. Next slide. So how should real data be collected? Next. So as Brianna said, the Office on the OMB, the Office on Management and Budget of the federal government recently, the end of March, put out new standards that had been in the works for quite some time. And it really allows for the breakdown in a different way. The two biggest things were they created new categories and they combined race and ethnicity, which takes some of that confusion out, some of that barrier out. They are still allowing people to collect the data in 3 ways, and we're going to talk more about that. Next slide. So the first way is really a detailed way, and it is, in my mind, the most preferred way, particularly for maternal child health, and we'll talk about that in the breakout. But it's where you can choose your race or ethnicity by checking the box, the major box. So American Indian or Alaskan Native, Asian, Black or African American, Hispanic or Latino, Middle Eastern or North African, Native Hawaiian or Pacific Islander, and white. And then there's sub boxes that you can check underneath for each category. And then if your sub box is not represented, you can write in one of the others where they offer you examples. So for instance, Black or African American, you can check African American, Jamaican, Haitian, Nigerian, Ethiopian, Somali, but then you can also put it right in Trinidadian, Tobagan, Ghanaian, Congolese, etc. And why this is so critical for maternal child health is we know that African American women experience higher infant deaths than our counterparts who are born in other countries until that next generation. So if we are truly to see change and really understand the data, we need to be able to tease this out. Similarly, the state of New Jersey had put out a bill, and it was S2415, I believe, that had broken out Middle Eastern, Asian categories, and I believe Native Hawaiian or Pacific Islander. And I might have gotten that wrong, but it has since, it didn't go through, which I'm happy that it didn't go through because it wasn't complete. They didn't break out Hispanic or Latino, and they didn't break out Black or African American. So I'm hoping that they retool it, rewrite it, and reintroduce it so that it goes through with all of these categories. And I'm hoping it didn't go through because they knew that this was coming to bear and that they can strengthen it with all of these categories, and that they make it mandatory for anyone receiving dollars from the state or who is being accredited by the state. OMB also gave a second option for collecting data. Next slide. The second option allows for just examples. And you check the major heading, and then they give you examples. So not as robust as option one, but gives you some examples. And then the third option, next slide, allows you to, is a more simplified version where you check the major category and they give you no examples, which I wish they had foregone this option, but no one asked. Well, they did ask people's opinion. They had time for comments, but I guess they wanted to have a simplified version too, but I'm hoping that at some point they only go with option A and we can do away with this. Next slide. So in the breakout, Tracy's going to lead us in our breakout portion, and we're really going to talk about, we're really looking for input from all of you. Who should be collecting the data and when, and really hearing about what's going on in your facilities, who's collecting it, what's working, and when that should occur. Why does this matter to maternal child health outcomes, and how we can map this to map the action themes, really workforce, data, payment systems, and social supports. Thank you so much.
Thank you so much to the Outcomes Architects for a wonderful presentation. I know that we will hold those questions for the breakout room, but if you want to continue the conversation with DeAnna and Tracy when breakout room time comes, please make sure you select their room. Next, I'm very excited to introduce our follow-up speaker, who is Katie Stewart from the Leapfrog Group. Katie Stewart is the Director of Healthcare Ratings at the Leapfrog Group, which is a national nonprofit using transparency to drive improvement in the safety, quality, and affordability of U.S. healthcare. She manages Leapfrog's various measurement and public reporting activities, including the Leapfrog Hospital Survey, Hospital Safety Grade, and Ambulatory Surgery Center Survey. As a director, she oversees operations and informs content and analytics for all ratings programs. Since joining Leapfrog in 2014, she has managed Leapfrog's maternity care expert panel, guiding efforts to build on Leapfrog's robust maternity care reporting, including adding information on NTSV C-sections, and most recently, collecting maternity care data by race and ethnicity. Katie, so happy to have you join us for today. We are getting your slides up and looking forward to hearing your presentation.
Thank you so much. And good afternoon, everyone. So a little bit about the Leapfrog Group on the next slide. For those of you that aren't familiar with Leapfrog, we are a purchaser-driven nonprofit born out of the movement for healthcare transparency, founded in 2000, in response to the 1999 Institute of Medicine report, which I'm sure many of you are familiar with, to err is human, which found just an astronomical amount of medical errors happening in hospitals. So a group of purchasers, many of which are on this slide, large employers that are paying for care for their employees, they got together and really with the goal of they wanted to have the best care for their employees and at the best possible price. So with that, they founded the Leapfrog Group. And really, we're driving change by empowering purchasers and consumers and using transparency to drive improvement. Our data is national in scope, and it's used by national and regional health plans, employers, groups like the New Jersey Quality Institute, employers, transparency vendors, and consumers. Next slide. So how we do this is we collect data directly from facilities. So we have the Leapfrog Hospital Survey, which is our flagship program, as well as our Leapfrog ASC survey, where we collect data from surgery centers. And then we analyze that data and report it out. We also have our other programs which analyze data, our hospital safety grade, which you might be familiar with, our A, B, C, D, or F letter grade assigned to general acute care hospitals throughout the US, as well as a program used by health plans that provides benchmarking among facilities, which is our value-based purchasing program. And that is used in the state of New Jersey, actually. Next slide. We publicly report our results, so I encourage you to take a look. What I've shown here is our maternity care search, which we launched this year. We have been collecting and analyzing data from hospitals and in turn scoring and publicly reporting that information for over 20 years. So we, you can see here when we first started, actually, we only had about 200 hospitals, and now we have almost 2,300. And what you've seen here is the maternity care search, which we launched. Not only can you look for specific services, so can I bring a doula with me? Do they have midwives? But also I can see if they meet various performance metrics for maternity care. Next slide. I mentioned we have almost 2,300 hospitals participating. Over 60% of hospitals participate in our survey, and that's about 73% of US hospital beds, since we do have a lot of larger hospitals participating as well as small hospitals. To date, we have had over 600 ASC participate in the survey. We're looking to continue to grow that program since we launched it in 2019. Next slide. So why would a facility participate? This is self-reported information. It does take time and effort, but really it allows facilities to demonstrate their commitment to improving safety, quality, and to being transparent, which is important not only for consumers, but also purchasers and health plans. It also allows them to see how well they're doing and compare themselves to their peers, identify areas for improvement, and clarify what they're doing well and where really, where they can be recognized for success. Maybe they're asked to participate by employers and other organizations like the New Jersey Healthcare Quality Institute. And thank you, Adelisa, for putting our public reporting website in the chat. Next slide. I wanted to share briefly the impact of this. So we've had great success in showing how transparency can really drive change. So what I've shown here is an improvement in quality, really, is what it drills down to. So when we started looking at early elective deliveries in 2010, we had rates of 17% or more average. And in just 5 years, we went to 2.8% in 2015. And we continue to see progress and really sustained improvement. And this is what we call, in Leapfrog terms, a giant leap. So this is done through the efforts of many, not just Leapfrog, but we worked, together with efforts done by the March of Dimes and the Catalyst for Payment Reform and National Business Group on Health, their efforts and certainly efforts done at the state and local level. Also in New Jersey, great effort around this to not pay for early elective deliveries, working with local business coalitions, and we saw great success, which transparency and reporting that information certainly helped to move the needle forward. Next slide. Another example is episiotomies. We are the only organization to track and report this nationally by hospitals. So you can see how the hospitals in your area perform. And we have seen dramatic and really commendable progress since 2012 when we first started publicly reporting. We are now, the national average is below our standard of 5%. And next slide, I'd really be remiss if I didn't talk about areas where we still need to see improvement. And that would be with, a couple areas, but certainly with NTSB C-sections if we're looking at maternity care. We use the measure used by the Joint Commission. It's known as NTSB C-section. So it looks at first-time moms that have reached at least 37 weeks gestation. They have one baby, and the baby is in vertex presentation. So it's what some might consider a low risk population of needing a C-section. And really how this has been explained to me, which I like, is it's really a measure of how well labor is managed in a hospital. And you can see that we have not seen much improvement, if any, certainly not sustained improvement, and we have not yet reached our standard of 23.6%. That is a Healthy People 2030 goal, and that isn't zero because there are some reasons why this population might need a C-section, but we are really far from meeting that target. And I'll talk a little bit more about efforts that we're doing to try to continue to make improvements in that area. So next slide. Our approach to health equity and really the role that we are contributing to improving health equity is to eliminate differences in the safety and quality of care delivered in hospitals and surgery centers, and really highlighting those differences. That is what we have done historically, is making sure consumers and health plans, providers know that there is a difference in the quality of care received in a hospital. And so we'll continue to use that approach as we look at health equity, which I'll talk about on the next slide. So we have previously worked with the Urban Institute to look at two studies that showed relative to white patients, Black patients in the US are more likely to receive care at institutions that have higher rates of adverse safety events. We also saw in those studies that Black patients are more likely to experience adverse safety events, even when admitted to the same hospital as white patients. And so we wanted to look at disparities in safety outcomes and see if they exist at higher rated hospitals. So using the Leapfrog hospital safety grade of A and B. Next slide. We looked at patient safety indicators. So these are adverse safety events that most hospitalized patients are at risk for. And then we also looked at adverse safety events during or after a surgical procedure. We looked at that among white patients, Black patients, and Hispanic patients, and then looked at various cohorts. So A hospitals, B hospitals, and then lower graded hospitals, which would be your C, D, or F. Those are going to have higher rates of those adverse safety events. Next slide. Using discharge data from 15 states, and we included hospital records from more than 10 million patients. We adjusted the patient safety indicators for patient age, sex, state, income, based on zip code and payer type, and we looked at Black, white, and Hispanic. Next slide. So what we saw with the analysis is that while higher graded hospitals are safer for everyone, we see that Black and Hispanic patients are still at an increased risk of experiencing an adverse safety event, even in those A and B graded hospitals. Black patients have significantly higher risk of bed sores, blood clots, respiratory failure, sepsis, and internal bleeding after surgery when compared with white patients. And Hispanic patients have a higher risk of experiencing sepsis and respiratory failure. And even when we were just looking at A hospitals, we saw that the above was true. So that was looking at the safety grade. I wanted to look a little bit about maternity care, and specifically with C-sections, bringing us back to kind of our work that we've been doing there. This was a report done recently, which shows that we do know that there are differences in care as it relates to C-sections. This report showed that Black and Hispanic mothers were 21% and 26% more likely than white mothers to deliver by C-section. So a 20% increased odds of cesarean among using a measure that, again, is considered to be a lower risk population for needing a C-section. C-sections, we know they are a major surgery. They of course are necessary in some cases, but in general, they do come with significant risks. Next slide. This was a more recent study published last year by the chair of our maternity care expert panel, Elliot Main and his colleagues. And what we see and what we know by looking at Leapfrog results, which I showed earlier, is that cesarean delivery rates certainly vary among hospitals. And what this is showing is that there is, again, marked racial disparities that are unseen when reported in aggregate, if we're just looking at the hospital's overall rate of NTSB C-section. So this study looked at reasons for this large disparity between Black and white mothers in first birth cesarean delivery rates, again, looking at that NTSB C-section measure at hospital level variation, and found that cesarean delivery rates among Black patients is significantly higher, and substantially greater hospital variation than compared to other racial or ethnic groups. And furthermore, they found that the lack of difference in facility or patient characteristics between hospitals with low cesarean delivery rates among Black patients and those with high rates. So again, they controlled for, they looked at patient characteristics among those hospitals with low rates and those hospitals with high rates. And they found a lack of difference, suggesting really unconscious bias and structural racism potentially playing an important role in creating these disparities. Next slide. So what Leapfrog is doing, based on this information, we know that there are differences in these C-section rates. We, for the second year in a row, are asking hospitals to report on that data by race ethnicity. The race ethnicity categories you see here are based on categories used by other national organizations. Our survey, OMB, just as was previously noted by our prior presenter, they just changed these categories, so we'll be revisiting them. But we intend, and we're continuing to ask hospitals to report on this. And for the first year, we'll be confidentially sharing this back to hospitals so that they can see how their rates, and we'll be providing some comparison information so they can see how their rates differ among the populations included in their hospital. And then we do intend to also use that information for national and state level benchmarking with a report that we hope to put out this fall. Next slide. So in looking at the 2023 data, an early analysis shows, again, we are seeing differences, and 1 out of every 6 hospitals had a statistically significant difference in the NTSB C-section rates between white and Black women, with Black women having higher C-section rates in 95% or more of those cases. So we'll continue to look at this data. We're hoping to have more hospitals report in 2024 and again issue that report. Next slide. So the other work that we're doing in the healthcare equity space is we have been including a series of questions on our survey. We've done 3 years of fact-finding and have analyzed those responses submitted to our 2022 and 2023 surveys. And we, for the first time, are scoring and publicly reporting a national standard for both hospitals and ambulatory surgery centers, a standard on healthcare equity, which really focuses on a few main things. So first being the collection of patient self-reported demographic data. DeAnna mentioned self-assessment is important. We're looking at self-reported demographic data. Also, as was previously noted, there's a limited training among staff members. We're asking about that training for staff on best practices for collecting those data, which is very important. Thirdly, stratifying those quality and safety measures by patient self-reported demographic, and efforts to identify disparities and address them if any are found based on that stratification. Board accountability, and then public transparency. So are you reporting out those efforts to the community? And really our goal is to continue to urge hospitals and ambulatory surgery centers to address healthcare equity by implementing some of these fundamental practices and protocols that we are asking about in this question set. Of course, we're looking to further advance this as new research emerges on best practices to ensure that really all patients receive safe and high quality care. Next slide. What we saw with our 2022 results that informed the development of this standard and further refined is that about half of hospitals reported collecting 5 to 6 different pieces of demographic information. So we ask about race, ethnicity, spoken language preferred, written language preferred, and then also sexual orientation and gender identity. And you can see that the majority are collecting that race, ethnicity data, and spoken language. Next slide. We mentioned the importance of training earlier, and what we can see is that it is common, but what is still surprising is that it's not always happening. So, this standard does ask that hospitals and our ambulatory surgery centers are really training their staff to collect that data during registration. Next slide. We see over half, almost 70% are stratifying clinical outcome measures. And they're stratifying some sort of measure, and the majority are using clinical outcome measures, others process measures as well. Next slide. And then they are finding disparities in that data. And, most are stratifying by race, ethnicity, less so by language. And then based on that stratification, they are identifying disparities. I think that number is likely a bit low. Next slide. And then, of course, the important piece of this is not only collecting the data, but actually using it to make change and have action. So here you can see that over 70% are using that information to revise their policies or procedures, or to update their goals for quality improvement. And next slide. Well, they're reporting back to their board in general, it's a little over half. A lot are not reporting back to their community, kind of their efforts in this area, which speak to earlier kind of the importance of individuals understanding why the data is being collected and making it a standard practice, so that we can have a more robust data set to look at these disparities. And next slide. And that is my contact info. So that does conclude kind of what I had to share today. I'm happy to address any questions, but of course, I will be in the breakout session as well.
Thank you so much, Katie, for the wonderful presentation and for letting our audience know about some resources that are available to them. So before we get into the breakout rooms, and again, if you have any questions or comments, feel free to use the chat, and you can speak with our subject matter experts in the breakout rooms. But before we get into that, we are going to play a very quick game. It's low lift. It's just giving us all an opportunity to kind of decompress after those wonderful presentations. So I just sent a link in the chat. This game is only going to take us a few minutes. Really, the goal is to stimulate our creativity as a group and really to see how everyone either thinks differently or similarly. So what we're going to do is you are going to click on that link and you will see that there's a word posted on the slide. And we ask that you write the first few words that come to mind when you see that particular word. It can be a word or a phrase. And once you're done submitting that, you're going to press the submit button on the bottom of your screen. You are able to submit 3 responses per slide. And then once you've submitted it, we ask that you come back to the Zoom screen and you'll be able to watch as your responses as well as your peers' responses populate on the screen. If for any reason you can't use the Mentimeter, feel free to use the chat to put in some words, or you can also respond to any of your peers' words or phrases that might stand out to you. So our first word is demographics. I'm already seeing a lot of great words on here. Oh, identity politics. That is new. See poverty level, characteristics. All right, folks, and we are going to do the same activity, but we have another word. So if you can click back into the Mentimeter, we're gonna do our second word for today. Appreciate all of your responses for demographics. The second word that you should be seeing on your screen shortly is disparities. All right, folks. Well, we are having a couple of technical difficulties at this time with the Mentimeter, but rest assured, once we get it back up and working, we will resend it for all of your thoughts and input. But thank you so much for everyone who participated and submitted some responses for demographics. I am now going to pass it over to our lovely President and CEO, Linda, to introduce the breakout room section.
Thank you, Brianna, and thank you to all 3 of our speakers. We're looking forward to continuing the discussion. So you have 2 options, theme 1 or theme 2. You get to pick to continue this discussion. Theme 1 is improving understanding, collection, and use of real data. So that will be the conversation that DeAnna previewed, and it'll be led by Tracy in breakout room 1. And theme 2 is diving further into using stratified race, ethnicity, and language data, the demographic data that Katie from Leapfrog was just discussing. That'll be led by Katie and moderated by Adelisa. So that's theme 2. So if you could pick a room now, and you will be magically transported there for a discussion, and then we'll come back together and debrief so that everybody will get to hear a little bit of both. But please go ahead and pick theme 1 with DeAnna and Tracy, or theme 2 with Katie. We'll see you soon.
Hello, everyone. Welcome back. I hope you all had very fruitful discussions, and I'm looking forward to hearing from you all about that. So first, we are going to ask each report out person to really give us a summary of your conversation that you had in your breakout room. And then afterwards, we'll open it up to any questions that either were from the presentation or that just, were left unanswered from the breakout room conversation. So without further ado, I will pass it over to our speakers, or excuse me, our report out person from room 1.
So that's me, and thank you everybody from room 1. Please jump in if I massacre the point you made. It was a fabulous conversation and lots of information flowed very quickly. So we discussed the importance of everyone being involved in collecting real data, that it wasn't something that lived only at one level of a system, or even just at like healthcare institutions versus community-based agencies, that kind of thing. We also talked about patient registration workflows and how important they are to the process of collecting real data. And we discussed agreement across systems when there's information about one person in multiple systems. When it doesn't agree, that can be a real challenge. There was also a conversation about the importance of real data, making sure that we are clear about how the data is benefiting the community as we're collecting it. That we make sure that education about the process of collecting data happens at all levels of the organization. We got into some detail about that and talked about having like one-pagers for quick reference, and also the importance of really good training that included things like role plays and scripts and all those sorts of things. And that when leadership says there's commitment, that it really extends to allowing that time investment, all the way down to frontline staff and all the levels in between. We also talked a lot about the importance of transparency around that data. When you collect the data, what are you doing with it? When it goes into a system and the community never sees it again, that really doesn't, engender trust. And it's very important that we're being clear about what we're doing with that data. And also that when we do report back about that data, that we're doing it in a way that's clear and understandable for people in all different, specialties. So we're not just talking to data scientists or clinicians. We're making sure that we're including information for the community too. We did talk about the challenges that really, transparency and trust was a huge one, that is very important. And that data alignment is also important. And of course, accuracy. And system function, IT issues. We got some great information about, the details of just like, pressing one wrong button and you end up, doing something crazy and picking something you didn't mean to. So that has to be really something that we put a lot of attention toward. And really how the data is providing this idea of social support into the community, and that you're building trust, you're making sure you have involvement in the community. You're really not operating over here in isolation because we're taking something from you. So what are we giving back? And are we talking to you rather than talking at you, talking with you? So I don't know if anybody has anything to add. All right.
You did a great job, Carolyn.
Yes, echoing Tracy's remarks. Thank you so much, Carolyn. That was a wonderful summary of our very robust conversation that we will definitely need a part 2 to, because there's just so much more to talk about. I will now pass it over to breakout room number 2 to give us your summary of your conversation.
That's me. My name is Layla Aguilar. And this is my first time doing something like this. So Our question was, what resonated with us? And things that came up was, is it patient self-reporting, or is it the staff that is reporting for the patient? The information summary will go to the CEO of the facility or the hospital who verifies the information. In some cases, they're required to provide documentation of this. Are facilities being reactive or proactive with the data? And how is a stratification of the data handled? Is it just too much or just certain levels? Training is very important in learning how to do this reporting. Health equity measures, are they being reported also? Because when people hear health equity, it makes them nervous. Discharge, transition, care, and coordination. Capital Health System does this when they're discharged. Because postpartum follow-up, there's many who fall through the cracks. There's a lack of knowledge and no set standard. What, how, and why data is collected? What does it mean? How should it be interpreted? And what to do with this information? And one of the last things was, how should a consumer use the data? And how do you avoid creating conflict within a community of within the community that the hospital serves by this data coming out?
Yeah, thank you so much for that, Layla. I'm happy just to add in a few details. I think something that our group really talked about is just how can we have a lot more accuracy with our data, especially if it's being self-reported. And we kind of talked about how Leapfrog has different systems and benchmarks in place in order to ensure the accuracy of self-reported data. So to Layla's point, the data has to be submitted to the CEO for review. The Leapfrog survey also uses different logic techniques, and there's different quality data thresholds as well. And then Leapfrog also uses past responses as a way to follow up with any hospitals. And they also provide random documentation requests, and they also have staff that perform on-site verification. So it was a number of different ways that Leapfrog ensures that the data is accurate. And I think one thing that also stands out with us, just in general with our group, is just how New Jersey is continuing to use Leapfrog data and how much it's been embedded in our hospitals throughout the years, and how New Jersey continues to have 100% participation. So I think those were the main themes that a lot of our group talked about.
I forgot
really just
Jersey, and I have it written down here. Okay.
Yeah, and I think some of the things our group talked about was about what we all know to be true is really the value and need for real data. And as we start to explore collecting some of that data, how it leads to more questions, which I know Katie was talking about, is somewhere potentially they'll continue to grow the health equity questions on the Leapfrog survey, but is really getting into those more details about, not just are they training staff on the collection of the data, but like, what does that training look like? And who's trained and who's doing the trainings. And so just about the general need to continue to ask questions and push the needle to really make sure that we're, identifying those disparities accurately. And then what are we doing with that data once we have it? Again, it relates back to everything we've been talking regarding the need for training around how to understand the data and how to use the data, which as some of our staff already alluded to, we hope to bring everyone together for a convening in September to dive into it a little bit more deeply. Thanks, Brianna.
Thanks so much, Layla, Armini, and Adelisa for that recap from room 2. So, I love breakout rooms, but the only issue is that you can't get to the other breakout room because you're in the one that you selected. So we did want to open up some time and space for any of our attendees to use either the chat feature or the unmuting, raising your hand feature to ask any questions to the subject matter experts that maybe you were not able to ask earlier today.
Brianna, if I could just quickly chime in, not so much a question, but just more of a comment. I mentioned this at the top of our breakout session for the outcomes architect, and it's really just around, all of us asking ourselves the question, how can we actually ensure quality if we are not desegregating data? Because if we don't charge ourselves with that, then our clinical programs, our initiatives, incorporating community health workers, doulas, all of that, it almost undermines the work that we spend a lot of time investing in because we really don't know what the true outcomes are. Having data on an aggregate level, what it just shows us a generalization, which isn't always bad, and DeAnna spoke to that, but it doesn't really show us what are the initiatives that we should truly be investing in, especially when we think about our CBOs, or we think about folks who are doing boots on the ground work, and we can't really see the benefits or the fruits of their labor because we're unable to identify the specific populations that they touch or work the most with. And the last thing I would say is disparities are one thing, but the consistent loss of Black women, having a baby, which is supposed to be one of the most joyous times in a birthing person's life, is not acceptable. So we all have to become change agents, ambassadors around this work. It is a business imperative. We can't change the hearts and minds of everybody to care about this, but the bottom line does change it. So I do encourage folks, if you have a voice at the table, and we should all have a voice or make our voices heard about this, is asking the question, how are we collecting race, ethnicity, and language data? And obviously, futuristically, SOGI data, because many of us need to focus on that too, as well as disability data. There are some states where it is called REaLD, where they are, in fact, collecting disability data as well. So that is really just kind of my call to action for folks who are starting to have conversations around this, is really motivating folks to think about the clinical aspects of the programs that they're investing a lot of dollars in. If you can't really desegregate the data, how do you know where the disparities lie? And how do you actually think about reimbursing in providers, clinicians in certain programs if you can't see what they're actually doing?
Thank you so much for that last comment, Tracy, and thank you to all three of our expert speakers, and really to all of you for your participation today. We greatly appreciate it. I want to echo what Tracy just said, and really just all of the sentiments about making this actionable and meaningful. I serve on a quality committee of a hospital here in New Jersey, and I've seen them pull up their data and look at it by race and ethnicity, not language yet, although I agree that that is so critical, and have really been able to be part of the conversation where people listening are taking that next step to say, wait, why is that the case? Why is that disparity there? And what are we going to do about it? And that's really where we get to true quality. We don't have quality without equity. And so that is really why we want to focus together with all of you on figuring this out. How are we going to advance the training, the education, the awareness, the connection back to community, and then really making a difference to achieve equity within quality. So with that, thank you again to all of you. A couple of plugs here. I think a slide's going to pop up and spare us of that bright green behind me. Yes. I wanted to give you a reminder that literally tomorrow, we are having an in-person session where we just recently, as of last night, released a paper on advancing midwifery practice. And you are going to be invited to a half-day session and a presentation from Magda Shaler-Haynes on the paper, and a discussion around evidence-based approaches to update our regulatory climate to advance the practice of midwifery. And I know many of the members of our Maternal Infant Hub are on this webinar today. We thank you for all the time you've put into the topic of midwifery practice, and the Burke Foundation as well. And if you haven't registered for this conference, I think we can probably fit you in, but please do so right now if you're interested. And again, that's tomorrow. And also wanted to flag for you that in June, we are having another one of these work sessions. The topic of that one is on maternal mental health. We will be discussing perinatal mental health first aid, and also sharing the work of Great Expectations, which is a community-based organization here in New Jersey that does fantastic work on behalf of individuals with substance use challenges. So please register for that. And you can also look for registration for our in-person event in September. And right after this, there will be a short survey. So we hope you can stick around to take that. And thank you again for participating today, and for working with us on the Maternity Action Plan. This is a group effort to advance this topic and the changes needed here in New Jersey. So we appreciate you being our partners in all of this work, and look forward to seeing you both virtually and in person soon. Thank you.